again. I'm Dr. R. Deuk, and for those of you who were just with us a moment ago, we saw our first patient out the door 30 minutes after he came out of surgery. And as you can see, he's up walking around with his wife, and he's very happy. He was a 3-level, left side L344551. Remember, we did the discogram, and he had concordant pain that was 9 and 10 out of 10 at L344551. So his back pain's gone. His leg pain and leg symptoms are gone. He's not under the effective anesthesia. He's awake, alert. We didn't give him any pain medication. So he's basically a little bit groggy from the anesthetic, but anesthesia that causes grogginess is not the same as analgesia, which means pain relief. So basically he's a little groggy, but he's feeling everything. And he's going to be able to enjoy his holiday season with his family. What is it? What is it?
The blood pressures.
What do you want me to do? That's what you've got to do.
Boatloads of anything.
Doesn't matter. I don't want to hear it.
Okay.
I don't want distractions unless you really need my attention.
The reason is that you're concerned about bleeding last time.
Yeah.
So blood pressure is.
You don't understand. It has to be 110 or lower. So if you can't get it to 110, we're aborting. That's what you need to be telling me.
Okay, then you will have to wait. Because
I'm not going to wait.
well, the pressure was 210 over 120.
That's too high.
Now it's 176 over 91. With 20 of hydraulic.
Okay, Dr. Calcarni, let me make it so simple for you. If you can't get the blood pressure down, we have to postpone the surgery. It's simple. And I don't mind postponing it. I want to do what's safe and right for the patient.
You have to wait for
I don't know what waiting for a little bit. I'm not going to be here 20 minutes waiting. Okay? That's not appropriate. The blood pressure control has to happen before the patient gets here.
I have been on, she took everything. I had her take everything.
But she may need to go see her doctor and get other things.
She did have beta blockers from last time. So anyway, you have to give me a second because
I can give you a few minutes, but that's it. If we can't get the blood pressure under control, we're going to abort the surgery again. And this patient, it's not, yes, it is up to me. And that's what we're going to do. So I'll give you a chance to get the blood pressure under control. If you can't do it safely, then we're going to send her home. She's going to go see a cardiologist, and she's going to get that blood pressure down below 120 systolic, and then she's going to come back and have her surgery. Okay? But I'm not going to sit here in the operating room with a patient who has blood pressure out of control. And if you have to lower it safely. Does that understand?
yes, sir.
So if you can't do it safely in a few minutes, then don't bother. We need to send her home. All right, so Dr. Deuk, we're getting ready to do our second laser surgery, but we are, as every patient in the world presents us with different challenges, our challenge with this one so far is going to be blood pressure. And right now the blood pressure of the patient is too high to proceed with surgery. So we're waiting for the anesthesiologist to get the blood pressure under better control. This is one of the challenges that we have doing surgery on patients safely, but it's not something I'm willing to compromise on. See, blood pressure that's out of control for a patient having surgery could lead to death. It could lead to cardiac arrest. It could lead to pulmonary edema. It could lead to excessive bleeding. So I'm not willing to proceed with an elective surgery that could be postponed and done safely at another time with a patient with blood pressure that's out of control. We had to cancel the surgery last time due to bleeding. This time we may have to due to blood pressure. So we're just going to wait and see if our anesthesiologist can get the blood pressure under control safely. And what that means is you have to drop the blood pressure to a normal level, but you can't drop it too fast. So any questions for me while we're waiting?
We do actually have one. One of our viewers wonders, Dr. Deuk, if you ever herniated one of your discs, who would you trust to do surgery on you?
Great question. So if I ever herniated one of my discs, who would I trust to do surgery on me? Well, let me answer that. First of all, there's nobody that comes to mind that I would trust. There is a doctor who I think is the most anal compulsive, cautious neurosurgeon I've ever met in my life, but he does brain surgery and he doesn't really do spines. It doesn't mean he couldn't do a spine, but I would want to discuss that with him. And that's Dr. Roper, Stephen Roper. He was my mentor at UF. And he's extremely cautious, but almost to a detriment. So I would probably not trust him, though I like his cautious nature. There is one person I would consider trusting in Phoenix. His name is Dr. Anthony Young. Anthony Young, Y-E-U-N-G. He was one of my mentors to teach me the endoscopic technique. The only problem with Dr. Young is that he doesn't do my technique, and he's near the age of retirement, if not past the age of retirement. And there's nobody in his facility that I would trust to do my surgery. His own son, named Chris Young, is also an orthopedic spine surgeon, but Chris likes doing open surgeries, fusions, and stuff like that. Unfortunately, he didn't learn his dad's technique. So who would I trust? My own brother is a neurosurgeon. He's a spine surgeon in Tampa, but I wouldn't trust him. Not that he's a bad surgeon. He's a very good surgeon by most surgeon standards, but I still wouldn't trust him. If I had to pick one person, I would pick either my son or my daughter, and I would wait until they've completed medical school and residency, and I've trained them for a year or two. If I don't have the luxury of waiting because it's an emergency, I think I would trust Dr. Kelly Foote. Dr. Kelly Foote and I trained together in Gainesville, and I trust him enough that he would be the one to do my surgery if I needed it emergently. Dr. Kelly Foote. Plus, he's a really nice guy. Great doctor, compassionate. Are we ready?
150 over 77, it's coming down.
All right. I'll give it another couple of minutes, and then we're going to have to send her out. I mean, I don't want you doing anything unsafe. If it's unsafe,
I'm just giving more and more of antihypertensives.
I understand that. But if you drop her too much,
No, no, you're good. I would be happy to have you start here, but it's up to you.
I'm not starting at 150. It needs to be below 120. So if you can't get it there comfortably, we're going to postpone and have her see her cardiologist and get her blood pressure under better control. By the way, she's leaning on the side of the table like she's going to come off the table.
I'm just trying to bring it down so that
It's okay, ma'am. Just relax. There's not much you can do at this point, but try to relax and let us try to get your blood pressure down. Yeah. Luis, why is she laying on her side like that? Huh? I know, but ask the patient, why is she leaning to the side? Maybe. Ma'am? Ma'am, are you comfortable the way you're laying? Can you lay flat on the bed because you're leaning off to the right side? Can you lay flat? Yeah, that's a little bit better. Is it uncomfortable when you do that? All right, perfect. That's good right there. Huh? No, she's good.
foam. Because I want to for another pillow. Just give me a second. Lift your head up for me, sweetie. Good. Now turn whichever way you're comfortable.
Any more questions for me?
None so far.
Yeah, sure.
What's the most expensive fish you have in your tank that you use?
I don't have any expensive fish in my system. I've had them before and they die,
Yeah.
and then you kick yourself for buying an expensive fish.
Yes, sweetie.
You just got basic.
It's hurting?
Yeah, I have.
Oh,
What's
sorry.
going on?
But I was just holding her hand and where her ID is, so my hand up.
I look at fish now as workers, you know, employees.
Sweet doc, 134 over 65. And I'm going to continue to give her.
Yeah, I need it to be around 110 or lower.
Now, I have to start propofol at some point, and I need a little bit
I don't know what you're saying.
fat in the blood pressure so it doesn't fall too far down.
Yeah, like I said, I need it to be around 110. So for me, fish are really there to do work. So I use tangs, for example, and rabbit fish to eat algae. Algae kills coral, so you want to get rid of the algae. So you need fish that eat algae. I use wrasses to eat pests that kill coral, like a little snails and little nudibranchs and things like that.
Use yellow tanks.
I have yellow tangs, yeah. They're very good algae eaters. All right, let's get the fluoro in, if it's not already in position. I don't need that.
No. Okay.
Are you comfortable? Huh? All right, I'm going to give you some numbing medicine. Okay? We're going to hope that Dr. Calcarni will get your blood pressure down. If not, there's still a possibility we have to abort your surgery. Okay? So,
Let's start with epi. I know you won't, but just want to make sure. The local.
what about it?
Is it plain or with?
No, we always use epi.
In her case, I don't know. With her blood pressure being so, it's up to you.
I have to. It's not an option. All right, we're going to give you some numbing medicine. It's going to burn a little bit. And hopefully we're going to be able to move forward soon, but this is sort of in anticipation of that. Are we going the wrong way?
With the epi, I don't know.
Where do you live, ma'am?
Texas.
Texas? Oh, you're in MIMS for the winter? All right. Who's your cardiologist?
What she seen Dr. Duncan?
Well, that's your cardiologist then, right? Has he been working on your blood pressure with you? Was your blood pressure an issue before? What's a little high? Okay. Do you keep a daily log of your blood pressures? So what do you normally run? I'm sorry? 125? That's normal. So why is her blood pressure so high?
I've changed cup both sides, forearm, arm, just to make sure.
No, her blood pressure was high last surgery too.
Yeah, she just needs some more potent drugs.
Some what?
She took some potent antihypertensives regularly. She took her lisinopril, she took her beta.
Is that something you want to try to manage or you want her cardiologist to manage?
No, I'm talking about after the surgery. I'm giving her all potent drugs.
Well, I mean, after the surgery, it seems like based on her log, she's fine. It's just here, there's a problem.
I've given her some fentanyl just to relax. She's relaxed, I think. You're relaxed, right, sweetie? I did not know her pre-op pressures were high.
How long till we get another reading? So she was at 200?
In the pre-op, she was 182 over 92. I did not know that. Here it was 240.
240?
I mean, around 2010 to 2015.
Sweet Jesus.
And this is after she has taken all her drugs.
Yeah. All right, so we're going to go ahead and abort the surgery. Sweetheart, I'm sorry, but your blood pressure is staying high, and it's too high for me to safely operate on you. I really do apologize. We're not giving up on you, but we need this blood pressure under better control. So we need you to see a cardiologist. That's really what it comes down to. Do you want to see somebody in Titusville? All right. Yeah, Dr. Jong is fantastic, but there's also doctors like Dr. Rao, Dr. Matthews. They're all very good. But I'll have Dr. Kalkarni reach out and talk to your cardiologist. Okay, I apologize. I wish it was something better, but we've been waiting here for a while and we're not able to get it down below 135. So we need you down around 100 to 110. Don't let her fall off the table, please. Just lay still, sweetheart. Well, folks, sorry about that, but we had to abort this surgery because we can't get the blood pressure under control. Not a common thing, but it's not worth the risk of doing surgery on somebody with blood pressure that's not controlled.
Hey, doctor,
Yeah,
she's asking who do you recommend he should see? I can call them.
Dr. Jong. Dr. Jong is fantastic. That's who I'd go to.
Okay, if someone could find his number for me, Crystal?
Yes.
I'll send it to you. I have it.
Thank you, doctor. I'm sorry. Yeah, like doctor said.
Well, at least you get the distinction of being the only surgery that I've canceled for elevated blood pressure. Luis, would you please make sure on the dictation is aborted due to sustained elevated blood pressure? All right, I'll come answer questions in the conference room. Okay, Dr. Deuk Majin back with you. For those of you still with us, we had to terminate or abort the surgery on this patient. Unfortunately, the blood pressure was too high. How does that happen? Well, the long and short answer is it happens because people have high blood pressure, and high blood pressure many times is not curable. It's only treatable. And so these people are on medication for their blood pressure, and if they're not on the right medications, then blood pressures can spike up to dangerous levels. And in this case, blood pressure of 200 is extremely dangerous, and this patient had a blood pressure over 200. So we are not able to get it down to a safe level in the operating room despite giving numerous antihypertensive medications. So the right thing to do would be to terminate the surgery before you have a complication as a result of the elevated blood pressure. Have the patient go see a cardiologist. The cardiologist's job is to give the patient medication that will prevent the blood pressure from spiking, and to monitor what's called a log, a blood pressure log, where the patient monitors their blood pressure with their own blood pressure cuff at home and records their daily blood pressures throughout the day and make sure that those blood pressures are normal. So I can tell you right now there is no way this patient's blood pressure is normal. And we saw normal blood pressures before surgery, but for some reason their blood pressure is out of control today. And that's not something we can fix right now. So since we can't fix the problem right now, today, before the surgery, or during the surgery, we really need to cancel the surgery, unfortunately. And that's obviously not wanted by the patient or her family. It's not wanted by us either. We have staff here on the clock, and there's no extra payments for canceling surgery, unfortunately. So everyone suffers as a result of this. But what it really represents for the viewer who's still watching and listening is something important to understand. To have a successful surgical outcome, you have to be prepared. And being prepared means you have to have all your ducks in a row, and there's lots and lots of ducks to do surgery. And one of those ducks is that the patient has to be medically optimized, meaning that their blood pressure, their blood sugar, their heart, everything has to be just right. And because we wait and make sure everything's just right, that's one of the reasons I've had 0 complications to date with this surgery. So for those of you saying, well, how do you have 0 complications? Well, I have 0 complications because I have rules that I follow with my patients and my staff and my equipment and my drugs. And if everything isn't right, I'm not going to move forward with the surgery. So what that means to a patient who's thinking about the surgery is, that if we move forward with your surgery, that it's being done properly and it's being done safely with an expected outcome, which is why our outcomes are so consistently consistent. All right, do we have a question? All right, can Deuk laser disc repair be used to treat herniations in the thoracic spine? The simple answer is no, it cannot. Can it really? Yes, probably, but it would require some very different steps that are not normally done, which I'm not prepared to do in a surgery center. One of those steps would be I'd have to remove a rib head off of your spine, which is pretty invasive, and you certainly don't really want to do that without really knowing for sure the surgery is going to work. So I would just generally say no. Deuk laser disc repair is not useful for thoracic disc herniation. Now let me say one more thing. In my entire career of 23 years, all I see is spine patients day in and day out. There's only 2 thoracic disc herniations that actually needed to be treated with surgery. Think about that. Thousands and thousands of patients, many of them with thoracic pain and thoracic disc herniations, but very, very few, less than 1%, need surgery on the herniated disc. So I know what you're thinking. Well, if you're not doing surgery on the thoracic disc herniation, then what are you doing? Great question. What it turns out is that most people with thoracic disc herniations don't have pain from the thoracic disc herniation, even though they have a thoracic disc herniation. Their pain is coming from something else, and that something else happens to be something called the facet joints. F-A-C-E-T, joints. Facet joint pain is the #1 cause of chronic pain by far, and that is most likely what they have. So facet joint pain is usually the cause of thoracic pain, even when there's a thoracic disc herniation. And you don't need surgery for facet joint pain. You need a rhizotomy. So don't give up hope. And if nobody can help you with a rhizotomy where you are, come to Deuk Spine Institute. We'll do it for you. Is that our last question? All right, thank you, everyone. Sorry about the disappointment of the second surgery, but unfortunately we did cancel it for patient safety, and the patient will be safe, and they'll be fine, but they need to see a cardiologist before we bring them back.